vaccine. So in terms of the high-risk group, we are pregnant women, healthcare workers, like the doctors and other nurses and other healthcare workers, they have high risks of getting the infection. People living with HIV, household contact, especially with someone who is infected with the virus. Men who have sex with men and people who inject drugs, they have high risks of getting the virus. Now, what is the burden? Because Hep B infection, as we say, about 3 million people are infected. Some of them are not aware. What is the burden as per someone who gets infected? We know Hep B is the leading cause of liver disease in Ghana, and it accounts for the majority of chronic liver disease we see in our hospitals. Anyone who presents with liver cirrhosis, the most likely cause in Ghana is likely to be chronic Hep B infection. And those who present with liver cancer, the most likely cause is also as a result of Hep B infection. What of liver cancer itself? What are the statistics that we see in Ghana? Is the second most common cancer among Ghanaian men aside prostate cancer, and it's something that we have to take note of. We know that the leading cause of cancer-related mortality in Ghana is from liver cancer. It means if you are having a liver cancer, you need to seek help in time. Otherwise, it may be difficult for you to survive from the disease. Most patients present at advanced age because of that. Sometimes it's difficult to manage them. And we know that the median survival often measured in months. Most of the people, because they present in advanced stages, sometimes you may not be able to do anything after the diagnosis. When you look at Ghana compared to other countries, we can also see that we also have a lot of there are other countries that are also challenging us, but Ghana is one of we are concerned about the mortality that we are having in Ghana here. So it's something that we have to take note. So as a disease, what is the burden and outcome in Ghana? What is the impact in our economic activities? We know that most of the people who are infected with chronic Hep B, they are at their active age, actively working. Some are recently married, some have gotten jobs, some are applying to go for jobs, and they are denied because they have been detected, and some of them are already having advanced disease. So there's loss of productivity. And then we know that for most of the care that we have, there's an out-of-pocket payment in most of the things that most of the investigation, the treatment that most of the people are affected with chronic Hep B. With the long-term disability, most of the patients that are infected, some of them may even be in the hospital for months, sometimes 2, 3 months, 4 months. They will not be able to do anything, and they are burdening even the immediate family that are taking care of them. They may not have time to even contribute to the work that they are doing. We also have premature deaths among those who are quite active working, and we have a lot of people, because the average age of most of the people that we see at our clinic, they are about around 42 years. So we know that at that age, most of them are actively working, and a lot of people depend on them. So it causes a lot of issues within the family and the country as a whole. So what is the biggest gap that we are looking at? We know that awareness and testing is the biggest gap. How do we detect? Because as the chairman said, viral hepatitis also like hypertension and diabetes. It will not show you that I'm there until the disaster happens. And it's the same as we are seeing in chronic Hep B and Hep C infection. So, and we know that WHO is working towards eliminating viral hepatitis, especially Hep B. So what is our target? We know that WHO target is that by 2030, about 90% of people should be diagnosed if you are suspected to have chronic Hep B infection. And what is the current trend in Ghana? Currently, Ghana, we estimate that less than 10% people know of their status. And we know that about 3 million people are infected. If out of the 3 million, 10% of the 3 million know their status, it means that we are not doing well at all. Only a small proportion undergo complete evaluation, and we know because of the financial implication that's actually involved in the investigation. So some of them may retrieve, and then they may end up coming late. We know that even fewer of them receive antiretroviral treatment. Some of them, you may put them on medication they are not able to afford. And then even they buy for 1 or 2 months, they won't be able to continue on the treatment, which is also a barrier to some of the things that we are looking at. So as I said, with the total infection versus diagnosis and treatment, I said that about 3 million Ghanaians are infected, and less than 10% of people are also diagnosed. And with annual treatment, we will know that less than 1% of people are on treatment. And WHO target is about 90%. It means that from less than 10% to 90, we have a lot of gap to fill. And that is why we're having this webinar for all of us to know that when we come together as a team, we'll be able to fight this silent killer. We know that there are a lot of barriers. If you look at the cascade for Hep B treatment in Ghana, for 3 million having the disease and less than 10% of people are aware of their status and few of them being on treatment. And we know that with the less than 5% being on treatment, only less than 5% of people are virologically suppressed, which means that we have a lot of work to do. And what are the things that are resulting to this? So we know that there's low public awareness, of which we encourage everybody listening to us today to at least make a point and just take this disease as one of your public awareness creation. Talk to people in your office, in your house, around your friends, so that they will also get to know that there's a disease called viral hepatitis B and they can go to screen. We also have what we call limited provider awareness. There are a lot of workers who are not aware. There are sometimes they get to the hospital, there are sometimes you talk to people about a B infection, they are not even aware, just because they've heard about it, but they don't know how bad and how dangerous it is in terms of causing complications to the liver. In terms of stigma, we know that there are some people, when they tell them they're infected with Hep B and someone heard about it, they don't want to eat with the person, they don't want to even sleep in the same house. Some landlord may even evicted some people because they've been tested Hep B positive. Some people have refused to travel, or some people have denied jobs because they've been tested positive for chronic Hep B infection. So the stigma is something that we have to fight against. Just like hypertension, diabetes, we don't deny hypertensive patients from taking over jobs. We don't deny diabetic patients from doing the same, but we deny Hep B people from doing that. So I think we need to look at it again. The other barrier is cost of investigation. We know that when you are tested positive for Hep B, because there are a series of tests you have to do, from liver function test to profile to viral load and then to the treatment. Because of that, a lot of people are not interested in continuing the treatment, even if they are detected. The other barrier we need to look at is limited routine screening outside ANC and blood donation. We know that in this country, the only policies that is available to make sure you are screened for chronic Hep B and C is when you are pregnant. And that is the only time they have to screen you. And there are sometimes it's only the Hep B that they screen, C they don't. And the other policy is the mandatory policies, those who donate blood. So if you go to the blood bank, you are supposed to be checked for Hep B and Hep C before you donate. So these are the only policies. Otherwise, there's no policy to screen everybody. And that is why we're encouraging that every Ghanaian should know his status. And that will help us know those who are positive, and then we'll go on to prevent complications. What are the missed opportunities? Sometimes we have family members who are positive, we don't encourage them. And if you're a doctor in your family, you don't know their status is better, you advise them to go and do that, and then it will help prevent other complications. Household contact testing is very important. If you know someone who is positive, advise the person to allow all the brothers, sisters. We know that sometimes maybe with the related complication, liver cancer can cause havoc to some families. For HIV clinics, if they come, try and add Hep B testing to it and Hep C testing to it. For non-communicable disease like hypertension and diabetes, when they come, some of them come with fatty liver disease. We advise that use that opportunity to screen them for Hep B and Hep C too, especially Hep B because of the prevalence of it. And workplace screening, we encourage all staff, all managers, all directors to encourage their workers, do yearly, monthly, 6 monthly medical screening for them. And when you are doing the screening, then just check for diabetes, hypertension, height, weight, heart, Hep B, and Hep C. You are saving lives if you do that. Now, what are the options for prevention? We know that vaccination remains the cornerstone for prevention. We know that for childhood prevention, that one started in 2002. As a result of introduction, they introduced the expanded program on immunization. We know about that one that started some time ago, meaning that all those children who were born um, after 202, they are safe. And those of us who are born before then, it means that we are endangered species. And that is why we have to encourage all adults, even though children, some of them are still having risks, to get to know their status, because we know the vaccine covers more than 30%. For birth dose vaccination, which is the most effective intervention against mother-to-child transmission and early infant transmission, is the best way to go, and it should be administered within 24 hours of birth. And that one would help to reduce the transmission. Ghana has approved nationwide introduction, which we are working towards implementing it. And we hope that as soon as possible, if the Minister of Health, Ghana Health Service, and then all the agencies come together, we'll be able to implement the Hep B birth dose. As I said, why birth dose vaccine? Why does it matter? And the main reason is that we know that approximately 1.5% of children under 5 years still screen positive for hepatitis B despite childhood immunization with Hep B vaccine. That is containing the pentavalent vaccination, which means that not all who are being vaccinated with the normal immunization will be covered. And we know that some of the children their mothers may not give birth to them at the hospital. Some of them may not attend antenatal clinic. There may be short of vaccines available. So many factors. People also even refuse to take vaccine because they think the vaccine causes more harm to the children. So they don't like to do that. So these are some of the factors that we have to look. But if the birth dose is introduced, it means that it will end up reducing this gap that we see here. Now, what are the additional prevention measures that we can undertake? First, save blood. Every blood must be screened, and then make sure that well screen, not just screen, and with the right test kits that will help to prevent transmission. With infection prevention and control at the workplace, especially those undergoing procedures, they have to sterilize the machines very well. Those are doing tattooing and other. Even with the common barbering shops and salons we go, we have to be sure that all the machines are sterilized, because there may be some signs of form of infection if the sterilization is not well done. Safe injections, I know we do, but we still need to practice more. For mother-to-child transmission, of which we are working hard, because of the government is also trying to introduce what we call the triple elimination that involves HIV, Hep B, and syphilis. So meaning that if that one's also introduced, it will help to detect a lot of people, a lot of pregnant women who are likely to be infected with chronic Hep B. For vaccination of healthcare workers is very important. If you're a health worker or you have high risks of contacting such people, it's better you vaccinate yourself and your immediate family. For household vaccination, we encourage you to vaccinate your whole house, because you don't know where you don't know where they would get infected or contact with people who may be infected with the virus. For treatment options available, we know that the first line is tenofovir. There are other ones available, but we know that anyone who is on treatment, it prevents liver cirrhosis, liver cancer, it reduces mortality, and then all these ones would help you to reduce the mortality and morbidity associated with chronic Hep B infection. So, but the challenges, what do we see? Most eligible patients remain untreated because they cannot afford, the drug is not accessible. There are limited access to Hep B DNA testing. We can count the number of labs, the number of a hospital that can test for viral load. So it's very difficult to assess this one at the village, at the community level. There's also lack of wide-scale decentralized care, and that is why we are coming out with training, and we want every doctor. For viral hepatitis cannot be treated by the gastroenterologist in Ghana. Everyone should be trained to treat it at the district level. It's very important. And because there's out-of-pocket payment and it's very expensive, people are not able to afford the drug. So we just need to take note of that. And what is the target by the WHO? We know that the target by 2030, there should be 90% reduction in new infections, and of which we are just doing about 10%. There's a 65% reduction in mortality, and we have the highest mortality in terms of cancers, liver cancer. We talk of liver cirrhosis and liver failure. If we add that one, it will be quite worse. We also have 90% diagnosis, as we said, less than 10% have been diagnosed. And less than 10% of our people, or 12% of our people are supposed to be on treatment, but ours, we don't have numbers to match this 80%. Now, when you look at what they expect, so for Hep B progress towards elimination, what WHO wants is that we are supposed to have 90%, but in Ghana, we have less than 10% or less than 10%. For 80% on treatment, we have not even gone beyond up to 20%. For the 90% BEV dose, and this BEV dose has not been introduced in Ghana to talk about. It's been covered 90% of our people. So it means that we've not even done anything. There's no target at all. So we are yet to start. For the EPI immunization as part of the pentavalent vaccination, I think we are doing well, which is about 90%. So we are doing well now. In terms of blood safety, we are almost 100%. We know that everyone who goes to the hospital donating blood, the blood is screened. For syringe and other drug users, we know that there are other organizations such as workers and other people who are fighting to make sure that those ones are done. But in Ghana, we don't have, I think the statistics are yet to come out. So for injection safety, we are doing very well. For now, we don't use one injection to inject two people, which is something that we are also doing well. So even though there are some that we are performing well, we still need to do more. So what are the priorities in Ghana? We need to increase the following on national scale. Public awareness, and that is where we are also coming in as a government, as the government is also working on other things, individuals, doctors, and civil societies can also come up, and there are a lot of them who are doing very well, and we encourage them to do more to create more awareness. And the media houses will help. We hope they will come on board to create more awareness on this. Screening, we don't have a national screening for viral hepatitis, so we just need to encourage, and we are hoping that we would probably come up with soon to see how we can screen everybody for viral hepatitis B. Linkage to care is a problem. Most of the people are tested positive. Some, they just go to the lab, they tell them they are positive. They end up giving them drugs and telling them, oh, it's dormant, you go home. They don't link care to the doctors, and then later on they come and they have liver cancer. For the BEV dose coverage, I think that is where we are yet to start. We've not done that. We are hoping that when we start, we'll cover the whole country. For the DNA testing, that's the hepatitis B viral load testing, we don't have. We are hoping that we work out with the reference labs, we work out with TB, we work out with other agencies to create more awareness, and then put the machines at all districts so that they will be able to access DNA testing. For treatment availability is not there. The drugs, if you go to the teaching hospitals, they have to buy. It's not covered with health insurance now, even though we are working to make sure that one is done. So availability is also a problem. We also need to integrate it into universal health care. So we are also pushing as a program to see how best the free primary health care can cover that, especially the screening, because you need to know whether you are positive or not before you can be referred. And then the cascade of care can be continual. If you are tested or screened at the community level, you can be referred to see a PA, see a prescriber, to see a doctor, to see a specialist, and then you will help to prevent complications. So just to let you know that from the program from Ghana Health Service and then from we are collaborating with other NGOs across the whole country, including Gaslit, as the main driver of liver care to provide affordable tenofovir. And this tenofovir has actually come into the country, and we are happy to tell you that we have a tenofovir that is available in most of the hospitals and some of the NGOs that actually collaborated with Ghana Health Service and then the international partners to bring it on board with and the cost of 76 Ghana cedis. I know the average cost in Ghana is about between 200, or if you say between 200 to about 300 per bottle for 30 days. So if you have such available, it will help. And we are working hard to see whether we can get more funding that can bring the drug into the country with a lesser cost so that people can afford, and then they can also even be covered by health insurance. So with this, what do we say? We know that from the National Viral Hepatitis Control Program point of view, Ghana Health Service, together we want to say that we can eliminate hepatitis as a public health threat in Ghana by 2030. And how do we do that? We need to find everyone. We need to test early. And that is why we need to tell the people that you need to know your status. Treat effectively when detected and when you meet the criteria. Because when we do this, we'll protect the next generation. Because we know that healthy liver, healthy life, healthy future, when we do that, it will help us to get to zero. So we are encouraging that for us to have a healthy Ghana, we need everybody on board as our shared responsibilities so that it will help us to prevent viral hepatitis B infection. Thank you very much.
Thank you so much, Dr. Adiboka, for this overview. Before we continue, we'd like to acknowledge the presence of the Director General of the Ghana Health Service, Dr. Samuel Kaba Akorie. We really appreciate your presence on this webinar. I would like to let everybody know that we will take our questions at the end of all the presentations. So you can write your questions in the Q&A box and it will be answered for you at the end. So our next presentation is going to be by Dr. Amwaku Dia. Originally, it was supposed to be by Dr. Adweje Nkanta, but this time around is going to be by Dr. Amwaku Dia. So Dr. Amwaku Dia, please, your audience, he's going to take us on hepatitis B and pregnancy. Thank you.
Hi, good evening. Can you hear me?
Yes, please, we can.
Okay. All right. Thank you very much for this opportunity. As he said, Dr. Adwa was supposed to do this presentation, but I'm stepping in her big shoes just to provide a bit of information about hepatitis B in pregnancy, especially in Ghana. And Amwaku Dia is my name. So briefly, we'll just look at introduction, which Gerard have spoken much about. I mean, the hepatitis B prevalence in Ghana. And then we will look at the management of hepatitis B and then how to take care of infant born to hepatitis B positive mother. So we know that, I mean, we find ourselves in an endemic country. And as part of that, the prevalence tends to be high, in Ghana. As was previously said, it ranges between about 8 to 12.5%. But when it comes to pregnant women, studies that have been done in this country, it ranges between 1.8 to 9.5%. And if you look at the trend followed that of the national prevalence. Okay, so more in the northern and then more in the western, and then some part in Greater Accra and then the eastern region. Okay, so the prevalence amongst the population is similar to what we found in pregnant women. And if you look at the progression of hepatitis B, all those who test positive to hepatitis B, especially if you are, it happens in childhood. Okay, about 90% of the children who get the infection develop chronic hepatitis B. And as Gerard said, in Ghana, the main mode of transmission, okay, when it comes to viral hepatitis B, is from mother to child, and then also early horizontal. And those who acquire hepatitis B through birth, about 90% of them will develop chronic hepatitis B. And those who acquired it less than 1 year, close to up to 70% will also develop chronic hepatitis B. So it means that if you are able to break the transmission, early childhood transmission, mainly from mother to child, and then also early horizontal, we should be able to reduce the burden of hepatitis B in this country significantly. That's why, caring for hepatitis B in pregnant women is very important. And we know that all those who develop chronic hepatitis B, up to about 30%, if you don't treat anybody at all, up to about 30% will develop liver cirrhosis and will go on develop decompensation and death. And up to about 10% will also develop liver cancer without passing through liver cirrhosis. We know that all those who develop cancer of the liver, close to 80 to 90% will have underlying liver cirrhosis. But for hepatitis B, you can go ahead to develop liver cancer without passing through liver cirrhosis. So hepatitis B itself is a carcinogen, okay? And we need to treat it. We need to treat it as such. So the main thing that I want to emphasize here is that if you are able to break the childhood infection, it means that you will be able to reduce the burden of hepatitis B death in this country significantly. And that's where the birth vaccination at birth also comes in here. Gerard Odu spoke about this. The unfortunate thing in Ghana is that because we acquired the hepatitis B early in life, its complications also manifest quite early in life. And studies that have been done in this country show that hepatitis B hit us, when we are at our prime age of life. So this study was done at Kolebu Teaching Hospital that shows that those who normally present with liver cirrhosis are in the middle age group, okay, around 45 years. And then the major cause of the liver cirrhosis is hepatitis B. And if you can see, alcohol also follow closely. So excessive intake of alcohol is not good. And I always tell people that if you are afraid of hepatitis B, then you should also be afraid of excessive intake of alcohol, because that one too can also damage your liver. This one was from a district hospital, St. Dominic's Hospital. That also shows that those who presented, the median age is 46 years, okay? And then you can see that hepatitis B was the commonest cause, 38.7%. But here you can see alcohol follow closely, 38.3%. We are not talking about alcohol today, but I just want to emphasize that excessive intake of alcohol is also can poison the liver, and it can cause liver failure leading to death. This study was published from Kolebu by Dr. Techi, and it shows that all those that develop cancer of the liver, about 75% of them is as a result of hepatitis B. And those who develop cancer as a result of hepatitis B, the age at which the cancer is developed is also around 42 years. Okay, so this tells us that hepatitis B is a burden, and there is a need for us to tackle this, as a national emergency. That's how I see it. We don't want to see patients coming in at this stage. Okay, we want to see a patient that we can screen and catch them and put them on treatment so that we prevent cirrhosis, we prevent cancer of the liver. This is the target, World Health Assembly. This is the target that we are supposed to meet. I won't go through it because Gerard has spoken about elimination of hepatitis B by 2030. Okay, but for us to be able to do this, we have to make sure that we encourage hepatitis B vaccination. We prevent mother-to-child transmission, which is very important. Safety injection and blood transfusion will reduce harm. And then test and treat. Okay, we should be able to do extensive testing, okay, screening, so that all those that require treatment, we put them on treatment. For me, if you give me hepatitis B topic to speak about it, even if transmission is not part, I'll bring in transmission because of the stigma that transmission of hepatitis B, is creating in our community. And Gerard have also spoken about it. Okay, that tells us that the main source of Hep B transmission is blood and blood product. Okay, and sometimes wound exudate. Semen, vaginal fluid, saliva, yes, but it's rare in terms of transmission through this fluid. So the main thing is blood and blood product. And as I have said already, mother-to-child transmission early horizontal route is the predominant mode of Hep B transmission in Ghana and other endemic countries. But the determinant of a baby getting hepatitis B from mother, a pregnant mother, depends on the E antigen and the viral load. So if the E antigen is positive and the viral load is also high, then the risk of the mother transmitting the infection to the baby is very high. So as I've already said, if a mother tests positive to surface antigen, just surface antigen alone, and the mother does not receive immunoglobulin and vaccination, up to about 40% of the babies of these mothers would acquire hepatitis B infection. Okay, but if E antigen is positive, okay, it's up to 90% of the babies will acquire Hep B infection if no intervention is done. And as I said, if they get it before 1 year, 90% will develop chronic Hep B. But if they develop or they get the infection between 1 to 5 years, up to about 30% will develop chronic Hep B. Okay, so that means that if you want to reduce the burden, we need to tackle the early transmission of hepatitis B. And studies have been done, as I said. If you look at the risk factors for increased rates of mother-to-child transmission, it's mainly positive E antigen and the viral load. So the higher the viral load, the more the baby is at risk of developing the Hep B infection. And they are also at risk of developing immunoprophylaxis failure. Okay, so immunoprophylaxis failure means that the baby will be born by a positive mother. The baby will receive both antibodies and the hepatitis B vaccine, okay, within 24 hours. But if the antigen is positive and the viral load is high, especially more than 200,000, okay, about 10 to 15% will experience immunoprophylaxis failure. Okay, so that means that it's not just good to know the surface antigen status of a pregnant woman. At least you should also know whether the mother is E antigen positive. And then if you can go ahead to know the viral load, it's very important in managing these mothers so that they don't transmit the infection to the babies. Okay, so if you look at this table, you can see if the surface antigen is positive, when the surface antigen is positive, only 3.1% of the infants went ahead to develop the Hep B infection. And if you look at this test, it tells you that even all the 3.1, they were E antigen positive. Okay. And then if you look at here, the E antigen positive, they develop, the higher the viral load, or the higher the E antigen positive, the more, you develop, the babies go ahead to get the infection. And if you look at here, all those who viral load were 200,000 and above. So the higher the viral load, the more the baby is at risk. When the viral load was less than 200,000, that is less than 6 logs, none of the babies, develop immunoprophylaxis failure. Okay, so it's very important we know the E antigen status and then the viral load of the mothers. Okay, and this one also tells us that the higher the maternal viral load, the higher the babies also, or the children, develop hepatitis B also at birth. Some studies have been done. There is this study that we did at St. Dominic's Hospital. We look at 51 mothers who tested positive to hepatitis B, during antenatal. And we followed them up. And at the end of the day, we realized that these mothers, when they delivered, about 5.9 of the babies, develop hepatitis B. Okay. And then we realized that all these 5.9, that was 3 over 51, all the mothers were also E antigen positive. Okay. So it means that there is a need for us to intervene when the virus is high or is detected during pregnancy. And studies that have also been done also shows that when you intervene, by giving the treatment to these mothers who have E antigen positive and have high viral load, you are able to reduce the immunoprophylaxis failure. So those that were given tenofovir, none of the babies develop immunoprophylaxis failure. But those who were managed, as a standard of care, those who did not receive any tenofovir as a form of prophylaxis during their 3rd trimester, if you look at here, about 7, and then 7%, if you look at here, about 2% went ahead to develop the babies went ahead to acquire the hepatitis B. So it's important, as I said, to know the E antigen status and then the viral load. Even if the viral load cannot be determined, then E antigen status have to be done. So in pregnancy, all mothers, as it is done in this country, or as it is recommended, receive hepatitis B screening, especially during the 1st trimester. But it will be very interesting to know that when you go to some of the centers, not all mothers are screened for hepatitis B surface antigen. Some of us have traveled around, doing presentations about hepatitis B, and it comes out that in some of this, National Health Insurance sometimes doesn't fully cover this screening, Okay, so they leave it to the mothers who can afford, and they do the screening for them. So it's not all mothers that are able to get screened for the surface antigen. And that's the one that the control program have to look at, so that we can catch these people, because it's an opportunity for us to get to know those who are positive and then to be able to reduce the burden. Okay. So once you test and they are positive, these pregnant women, need to know their results. They need to receive counseling, and they have to be linked to care. That is one thing that we fail to do. Our nurses and our ONG specialists, we don't link the mother to care. All what we tell them is that, what about the mother? What do you do to the mother? We leave them to their fate. And sometimes the unfortunate thing is that after delivery, instead of the mother staying alive to take care of their babies, they come in with cancer of the liver, they come in with liver cirrhosis, and they die leaving the babies. So linkage to care is very important. And as I said, we need to tell them about intervention to prevent them from transmitting the infection to their babies. Okay. The other thing too is that these mothers, as I said, should be linked to care and should be evaluated, okay, and see whether they have to be put on treatment or not. I think Dr. Atta will talk most about, management of hepatitis B. But these mothers should do the profile, especially to determine the E antigen status. They have to know the viral load. We need to test for other co-infections, HIV, hepatitis C, and then do additional workup, okay, liver function test, ultrasound scan, because this workup will tell us whether these mothers need to be treated, okay? And once they qualify for treatment, whether they are pregnant or not pregnant, we have to start them on treatment, okay? And know that tenofovir is safe, in pregnant women. The tenofovir disoprosyl formulate is safe, and recent studies also show that you can still use tenofovir alafenamide even if they are pregnant, okay? So tenofovir that we use to treat hepatitis B is safe in pregnant women. Sometimes when they are on it and they get pregnant, some of our midwives stop them from taking it, thinking that it can cause harm to the fetus. But that one is not true. They can still take it. But know that when a mother is pregnant, sometimes there is some alteration in their liver function test. So that when you are interpreting liver function tests in pregnant women, you don't over-exaggerate, okay? You don't over-exaggerate, especially the alpha-fetoprotein tends to go high because the placenta tissues produce alpha-fetoprotein, so it can make it go high. So when it is up, don't think that they have there is cancer developing in their liver. The albumin, hemoglobin, as you know, go down because of hemodilution. Okay, ALP go up as it comes from the placenta. Okay, and the total bilirubin INR, that one does not change, but the transaminase also slightly go down, or sometimes it's unchanged, especially in the second and then the third trimester. So if you are interpreting liver function tests in pregnancy, you should also be aware of these changes that can happen. Okay. So as I said, pregnant women with chronic hepatitis B and meet criteria for treatment, you have to put them on treatment. Okay. If they are already on treatment, just continue. If they are on entecavir, and entecavir is not prescribed for pregnant women, you can change them to tenofovir. Okay. And there are some women too that may not qualify for treatment, but they will require antiviral prophylaxis. As I said, once the E antigen is positive, it tells us that the viral load is very high. And I think Dr. Atta will stress on interpreting hepatitis B profile in patients that have hepatitis B. I mean, in Ghana, normally what we tell them, what our biomedical scientists write when they do the profile, and the E antigen is negative, antibodies is positive, then they write it there, inactive infection, non-replicating infection. And we base on that, and we tell the patient that, oh, you are not replicating, you don't need any treatment. Within 5 years, 10 years, they come with liver cirrhosis, they come with cancer. So most of the time, what I ask my colleague health workers who are not gastroenterologists is that all patients that you are diagnosing them with liver cirrhosis, you are diagnosing them with cancer of the liver, how many of them that when you do their profile is E antigen positive? Almost all of them are E antigen negative, but they are going ahead to develop cancer of the liver. So don't base on the profile to determine the activity of virus in any patient. Yes, we know that when the E antigen is positive, the replication is high. But when it is negative, it doesn't tell us that the virus is not replicating. The virus can still replicate because of the mutant form of hepatitis B in the system. Okay, so now the only true way that you can determine whether a patient have an active hepatitis B infection is to do the viral load. That is the only thing that can tell you. But as I said, if the antigen is positive, it tells us that the replication is high. But absence E antigen doesn't mean that the virus is not replicating. So let's take note of that so that we can give good advice to our patients and also manage them well. So once the antigen is positive, even if the patient cannot do the viral load and the person is pregnant, at the 3rd trimester from 28 weeks going, put that patient on treatment. Put that patient on treatment. If the patient cannot afford the treatment, I mean, for the rest of his or her life, I mean, you stop it. I mean, about 3 months after delivery, you can stop it for them. Okay. And when the viral load is 2,000 and above, I will not see a patient who have viral load 2,000 and above, irrespective of the liver function test or ultrasound, and I will not put the patient on treatment. Okay. For me now, the way I treat hepatitis B, once you are 18 years, viral load is 2,000 and above, irrespective of other things. I advise you so that you start treatment. And if you look at all the international bodies, they advocate for antiviral prophylaxis in pregnant women. Okay. They advocate for that, especially when the viral load is more than 200,000. You put them on treatment at 28 weeks. But for me, when I see this in 1st trimester, I will start treating you, because you know that the higher the viral load, the more they are at risk of developing cancer of the liver, and then there are also liver cirrhosis. Okay, so now the mentality is changing from treating the disease rather than the virus. Now the mentality is treat the virus, because the virus can cause cancer, the virus can cause damage. That's why treat or approach is catching up nowadays. But all the international bodies will recommend that you treat patients or you put them on treatment, pregnant women, when the virus is more than 200,000. WHO add E antigen positive, okay? Because sometimes WHO, when they are coming out with guidelines, they have separate guidelines, one from well-resourced and one from poor-resourced countries. Okay, so you can base on the E antigen alone and start treatment. As I said, put them on treatment, then you reduce the post-exposure prophylaxis. What happens to the newborn, okay, of a mother who was positive for hepatitis B? Within 12 hours, I mean, this newborn need to be immunized. So both the immunoglobulin and then the surface antigen. But we know that this can be a barrier. especially in countries like Ghana, where the immunoglobulin is close to, 1,000 Ghana cedis. How many pregnant women can afford, this, especially in our rural communities? Okay, so sometimes immunoglobulin tends to be a barrier. Okay, so also the National Control Program, Ghana Health Service, Ministry of Health, need to look at this if he really wants to reduce the burden of hepatitis B in this country. Okay, but know that without the immunoglobulin, you can give the vaccine to the babies whose mothers are positive. Now, you know that even if the mother is negative, vaccine is recommended in an endemic country like this at birth dose. Okay, but if it is not available and the mother is positive, you can give the surface antigen alone, because the surface antigen alone can give the babies about 75% protection. Okay, so the mothers that are positive, they cannot buy the immunoglobulin. When you give the surface antigen alone, the vaccine alone, it can give them up to, the babies, it can give them up to about 75% protection. But when it is both the vaccine and the immunoglobulin, then we get to about 95% reduction. And you know that the vaccine is cheap. The mothers can buy.
Yeah,
okay?
hello, Dr. Dia.
Don't deny them.
We'll be
Yes.
glad if you can round up in the
Yes,
next 5
please.
minutes. Thank you.
Yes, please. Okay, and so you give the vaccine immunoglobulin, and then you continue with the routine vaccination. So that means that at the end of the day, the babies will receive 4 doses. But those who are less than 2 grams, okay, the babies that weight are low, you make sure that when they are at 24 weeks, okay, 2 years, you give an additional dose, and that will help boost the antibodies. Okay. And when the babies are given both the immunoglobulin and then the antigens, immunoglobulin and then the vaccine at 9 to 12 months, these babies need to do the test. You test for both surface antibodies and then the surface antigen. Okay. And if it is more than 10 international units per ml, it means that they are protected. If it is less than 10, you can give a single dose. Sometimes it boosts the antibodies. But if it is none, what you need to do is that they have to do the 3 doses all over again using a different brand of the vaccine so that they can develop adequate antibodies. And you know now hepatitis B vaccine is for life. Once antibodies are produced, you don't need to give any booster. Okay, it's only health workers that boosters are recommended when the antibodies fall below 10, and then those who go through renal dialysis. Some mothers come and give birth without their surface antigen being checked, so we don't know their status. These ones, you need to treat them like those who are positive. Okay, who are positive. It helps so that it will reduce the babies getting infection in case the mother is positive. So the take-home points: all pregnant women should be screened for Hep B. And as you know, infants who get exposed, about 90% of them will develop chronic infection, compared to adults that less than 5%. So if you want to win the fight against hepatitis B, it means that we need to target infant exposure more than the adult exposure. Okay, but I think in this country, we target more of adult than infant exposure. Okay, and if you want to give the vaccine, to the newborns of Hep B mothers, the appropriate duration is you do that less than 12 hours after delivery. okay, to the babies. And HBV therapy needs to be discussed with expectant mothers. Okay. Flare of hepatitis B is uncommon in pregnancy. Studies that have been done show that less than about 9% of pregnant women will get a flare. Okay. So as I said, tenofovir is safe. To be given to mothers, especially the fumulate one. And then the TAF can be considered, as studies that have been done show that, it's also not teratogenic to the babies or to the fetus. And breastfeeding is not contraindicated. Okay, when a mother is taking antiviral therapy, when the mother or when the baby have not received both vaccine and the immunoglobulin, breastfeeding is not contraindicated because hepatitis B is less likely. Okay, it doesn't pass through breastfeeding to the babies. Thank you very much.
Thank you very much, Dr. Mwakudia, for that insightful breakdown of hepatitis B in pregnancy. Thank you all so much for your questions so far. We'll address all of them for you at the end of our presentation. We would also like to acknowledge the presence of
Okay.
Dr. Jibril Indo, Director of Research, Center for Operational Research in Hepatitis B at the Task Force for Global Health. We really appreciate your presence on this webinar. So our next presentation is going to be taken by Dr. Ezwa. He's going to take us through, I'm sure, what we've all been waiting for. He's going to discuss the diagnosis and management of chronic hepatitis B. Dr. Ezwa, your audience.
Good evening. I hope I can be heard clearly.
Very clearly.
All right. So let's begin.
Good evening, everyone. Welcome to the third lecture for today. My name is Dr. William Arthur. I will be taking us through the diagnosis and management of hepatitis B. I want to thank my earlier presenters. They have done very good jobs and have made my work much easier. So without further ado, I'd like us to spend just a few minutes on the topic at hand, the diagnosis and management of hepatitis. This will be the outline of my presentation. And we'll just briefly look at the virology of hepatitis B. I'm sure we've already been made aware that it is a DNA virus, and because it is circular and covalently closed, this is what makes it especially adaptable to chronicity when it invades the hepatocytes. We already know that it has a very high mutational rate, and some of us may be aware that there are about 10 genotypes. Is this important in therapy? Not necessarily so, because the therapy is more or less the same across board. Now, with regard to the epidemiology, the virus is unevenly distributed with a high prevalence that is seen in sub-Saharan Africa, Southeast Asia, as well as Eastern Europe. This can be attributed to quite a number of factors. And of course, we have seen that in the Western countries, that is North America, Western Europe, the burden of hepatitis B chronic infection is not as high as in the aforementioned countries. Now, with the clinical outcomes and natural history of hepatitis B, the progression from acute infection to chronic infection depends on certain factors. Primarily, the age of infection, because this is also related to the immune status of the individual. The damage from hepatitis B or chronic hepatitis B or acute hepatitis B is really because of the interaction between the virus and the host immune system. With greater interaction between the two, there's damage to the hepatocytes, and in chronic infection, the risk is the progression to cirrhosis and hepatocellular carcinoma. So the natural history really depends on the age of infection. Now, with perinatal infection, the risk of acute infection, that is from a child born to a positive mother, once this baby gets the infection, the risk of progression to chronicity is roughly about 95%. Now, in early childhood, when there's infection amongst children during rough play and so on and so forth, the risk of chronicity is about 30%. For a fully grown adult who's immunocompetent, who manages to contract the infection from one source or the other, the risk of acute infection progressing to chronic infection is just about 5%. So this tells us that the majority of our patients who have the chronic infection probably were infected perinatally or at least in early childhood. Now, for the natural history of chronic hepatitis B, we know that it has 5 stages. Now, the terminology has changed over the years, but the factors that make up each stage remains the same. In order to know the stage, we need to know the viral load. We need to know the presence or absence of the E antigen. We need to know the ALT, serum ALT, which tells us the level of inflammation taking place in the hepatocytes. If we have access to fibrosis scores in the liver, that also gives us additional information. Now, the first and second stages are marked by the presence of E antigen being positive. And this is usually seen early in infection, especially in early childhood and perinatal infection. So if we look at the table, we can see that for those who are E antigen positive, they are keeping the E antigen positive within the first 20 to 30 years of life. The very first stage with the E antigen positive is marked by a very high viral load, but a normal ALT and normal histology pattern. Previously, this group was termed immune tolerant because the immune system was more or less tolerating the presence of a high number of viruses. Even though the viral load is high, there was no damage to the hepatocytes. This is seen early on in chronic infection. The second stage, the E antigen is still positive. However, now the ALT has risen, and there's also necroinflammation taking place in the hepatocytes. Now, with this damage taking place in the hepatocytes, this is an indication for starting therapy. So if patients are seen at this stage, this is an indication to initiate therapy. Now, for the patients who move on to stage 3, the E antigen is lost. Once E antigen is lost, viral replication also winds down. These patients usually have a viral load in the low thousands with a normal ALT and normal liver histology. Previously, they were called inactive carriers, but the current terminology is chronic hepatitis B virus infection. Because there's no necroinflammation, ALT is low, viral load is low, these patients in stage 3 do not require therapy, but continuous monitoring. Some of these patients may progress where the viral load goes up above a certain threshold. The threshold usually, per most guidelines, is about 2,000. The viral load now shoots up above this threshold. ALT becomes higher, and then if you're able to do some liver histology assessment, we can see that there is also necroinflammation taking place. These patients are stage 4, currently called chronic hepatitis B, and they require therapy. Now, a few patients will progress to stage 5, and stage 5 is marked by the loss of the surface antigen. Now, the ALT is normal, viral load is undetectable, and these patients are stage 5. You may see 1 or 2 in your practice. Keep in mind that for those who are surface antigen negative, it may be stage 5 chronic hepatitis B infection. Now, we have gotten some idea as to the natural history of chronic infection. What can hepatitis B lead to in the long term? Now, we know that a lot of our patients may stay with a chronic infection with no progression to any untoward complications. However, the major complications that we are worried about are liver cirrhosis and hepatocellular carcinoma. What are the risk factors that lead to this? The single best risk factor that we know of, and many guidelines or many studies that have been done, is the viral load. The higher the viral load, the greater the risk of progression to hepatocellular carcinoma. And for those who have stage 3 active hepatitis, those who have stage 2 or stage 4 chronic hepatitis, the risk of progression to cirrhosis is about 20% in those who are not treated. Now, we have just said that high viral load is the greatest risk factor for progression to HCC. Other things that could progress or cause progression to cirrhosis are older age, male gender, and a greater stage of fibrosis when the patient is first seen. Now, other conditions that lead to hepatic inflammation, such as HIV co-infection, hepatitis D co-infection, ongoing ethanol abuse, and what was previously called fatty liver, have all been seen to increase the risk of progression to cirrhosis and hepatocellular carcinoma. Now, if we're talking about the management, diagnosis and management of hepatitis B, we have to start with the history. The incubation period is roughly between 2 to 3 months. But one thing that we should keep in mind is that quite a number of patients may be asymptomatic, particularly younger ones, that is the children. Those who do have symptoms have very non-specific ones, such as nausea, vomiting, joint pain. Some people have rash. 30% of patients may develop jaundice, which usually recedes or declines within a few weeks' time. The liver biochemical tests typically show very high serum transaminases in the very high hundreds to thousands. When there's recovery of the transaminases, the bilirubin stays high for a little bit, but it also declines gradually. Now, for the acute infection, it is marked by the loss of the surface antigen within the first 6 months. Typically, 80 patients will test negative for the surface antigen within the first 12 weeks of infection. Now, how do we tell a chronic infection from an acute infection? By definition, once a surface antigen is present for more than 6 months, it's chronic. But if a patient is being seen for the very first time and a decision needs to be made about therapy or otherwise, we can look at the hepatitis B profile and determine if there is a chronic or an acute infection. Unfortunately, a lot of the profiles that are done are quote-unquote incomplete. What we need is the core antibody. Now, from our basic immunology, we know that there are multiple antibodies present. The presence of IgM signals an acute infection or recent infection. The presence of IgG signals a past or chronic infection. So if you have access to a hepatitis B profile from a few advanced labs, and I can mention MDS Lancet and SynLab as typical labs, Once a profile is done, they will tell you the core antibody and go further to tell you which of the subtypes it is, if it is IgM or IgG. Now, if you do a profile and the core antibody is positive, go further and look at the IgM. If the IgM is reactive, it means that the hepatitis B is acute. If the IgM is absent, it tells us that the core antibody is in there as IgG. There straight away you know that you're dealing with a chronic infection. So that is the best way to use a profile to tell if your patient has hepatitis B, chronic or acute infection, at the very first time of interviewing this client. Now, for chronic infection, usually it's difficult to determine exactly when infection took place because most patients may not recollect exactly when it happened. Why? Because most infections are acquired perinatally or early in childhood. Most patients are asymptomatic, but the typical and the most common symptom, if they do have one, is fatigue. We read about in the book some of the extrahepatic manifestations. You may or may not see them in your practice: arthritis, nephrotic manifestations, and cryoglobulinemia. So we've talked about the diagnosis. Persistence of hepatitis B surface antigen for more than 6 months is tantamount to chronic infection. Once we have that, it's a chronic infection, we need certain other parameters to determine if this patient needs therapy or not. One of the most important is the viral load, as we have seen earlier. And then, of course, we need to know the person's liver biochemical testing status, primarily the ALT. Now, the hepatitis B surface antigen level is useful sometimes if you want to prognosticate certain things like liver disease progression, cirrhosis. If your patient is going to be put on pegylated interferon, it may help you make certain decisions concerning whether you will continue for the entire 48 weeks or stop early because there may not be a good response. Now, we should be aware that there are some new serum biomarkers that are being put to use. We have the hepatitis B correlated antigen, hepatitis B virus RNA. For the vast majority of us, probably would not have to request some of these tests, but it's good to know the advances that are being made in hepatitis B management. I'd like us to take a look at this hepatitis B profile, a typical profile of a patient who was seen at a hospital. And we can use this profile to determine, number one, if it is an acute or chronic infection. Number two, the stage of infection, so that it helps us to determine how soon we are going to start therapy or not. So if we look at the very top, we can see that the core antibody is positive. Now, the surface antigen is reactive, so we know our patient has hepatitis B. But this core antibody is positive. We ask ourselves, is it an acute or chronic infection? If it is acute, IgM should be reactive. If it is chronic, IgM will be non-reactive, which means that the core antibody we are seeing there is IgG. So here, the core antibody is reactive, but IgM is non-reactive. This straight away tells us that this patient is having a chronic infection. Now, which stage are they at? Stage 1, 2, 3, 4, or 5? Automatically, stage 5 is out because you know that for those patients, surface antigen is absent. So it's either stage 1 up to 4. And we know that one of the things that determines a stage is the presence or absence of the E antigen, as we said earlier. So when we come down here, you can see that the hepatitis B E antigen is negative. And if we recollect from the earlier slides, for those in stage 1 and stage 2, the E antigen is positive. So once this E antigen is negative, it means that our patient is either in stage 3 or stage 4. If we have access to the viral load and the ALT, we can know if she's in stage 3 or stage 4. And that will help us to determine if she needs therapy or not. All this information can be gleaned just from hepatitis B profile. Now, with regards to therapy, it can be a bit complicated sometimes, but this is the simplest way for us to understand. And I'd like us to take cognizance of this slide. Now, for those who have hepatitis B surface antigen positive, that is, they have the infection and it's established to be chronic infection, we need two things. We need the viral load, we need the ALT. Those are the basic things that we need. Now, let's take those who have a viral load that is less than 2,000. If the viral load is less than 2,000, the ALT is normal. It means that there's little to no inflammation taking place in the hepatocytes. If there's no inflammation, there's no damage. And therefore, you can continue to monitor your patient at intervals. Monitor the viral load, monitor the ALT. Now, for a patient whose viral load is less than 2,000, but the ALT is persistently elevated, again, the fact that the ALT is elevated could be from something else altogether. So we'd have to find out, is there any other potential cause for the ALT being high? Is there hepatitis C or D co-infection? Is the patient taking excessive amounts of ethanol? Do they have what used to be called fatty liver? And from that, you can make a decision. Now, for patients whose viral load is greater than 2,000, who have an ALT that is normal, keep in mind that we said that for those in stage 1 and stage 2, viral load is already high. Now, if the ALT is normal and the viral load is high, again, there's little to no inflammation taking place, little to no liver damage taking place. So we continue to monitor these patients. If you're worried that there's something happening underneath the surface, assess the need for fibrosis or assess the presence of fibrosis. This can be done invasively with liver biopsy or non-invasively with certain calculators and also with a transient elastography. For the patients whose viral load is greater than 2,000 and ALT is persistently elevated above the threshold, there's inflammation taking place, there's liver damage taking place, start therapy straight away. In 2024, the WHO came up with new guidelines meant for the global south and resource-poor countries, because a lot of the guidelines that were being used had been designed in first world Western countries, the European Association for Study of Liver Disease, the American Association for the Study of Liver Disease. They had come up with their own guidelines. But the study subjects and those that made up those guidelines differ from those who bear the brunt or who have the highest prevalence of hepatitis B, that is sub-Saharan Africa and the Southeast Asian nations. And therefore, there was truly the risk that a lot of patients who should have been on therapy were being excluded because of rigorous adherence to these Western guidelines. And so the WHO came up with expanded criteria so that no one would be left out inadvertently. We can see from some of the bullets, and I'm not going into detail, but I'll highlight the most important thing. And this is what we should all take away from this presentation. That if we're able to determine the presence of fibrosis as evidenced by risk calculators or biopsy or the presence of cirrhosis, these alone are evidence of damage taking place as a result of hepatitis B, and thus patients need to be started on therapy immediately. Now, if the viral load is greater than 2,000 and the ALT is above the threshold, we start. The threshold is now the main question. We know from the labs that we look at all the time that ALT upper limit is usually about 40. But with regards to hepatitis B, the upper limit has been taken as 30 for men and 19 for females. So once the ALT crosses this threshold persistently with a viral load greater than 2,000, there's damage taking place. Therapy should be started. The third indication, once there's co-infection from hepatitis D or C, start therapy. Once there is a family history of liver cancer or liver cirrhosis, irrespective of viral load, irrespective of ALT, start therapy. If the patient who has hepatitis B is going to be put on any form of chronic immunosuppression for cancer, for autoimmune disease, they should be started on therapy. Once the patient has diabetes and or fatty liver in the presence of chronic hepatitis B, irrespective of viral load, irrespective of ALT, start therapy. Now, if the patient happens to be in a part of the country where access to regular viral load monitoring is difficult, of course, we can still look at the ALT. If it is above the threshold persistently, then you err on the side of caution and you start therapy. What drugs are used in managing hepatitis B? Now we have the nucleotide analogs. Lamivudine was once the first line, but because patients quickly develop resistance in the first year of starting therapy, it is no longer recommended as first line. The same for Adifovir, the same for Entricitabine. Entecavir is safe, well tolerated, and can be used for therapy. In our part of the world, it's a little bit more expensive, a little bit more difficult to get, but it can be used. The drugs which are most widely available, most readily accessible, are tenofovir. We have tenofovir TDF and tenofovir TAF. TDF, safe, reliable, accessible, but for patients who have an underlying renal pathology or risk of renal disease, it is safer to use TAF, which is a little bit more expensive, but just as effective. These are the first-line nucleotide analogs used in the management of chronic hepatitis B infection. How long can they be used? Let me answer this question before we go on. Now, hepatitis B is a chronic infection. Cure rates very low, if at all. Now, once a patient is able to lose the surface antigen, that is a quote-unquote functional cure. So, if by some form of intervention, once your patient is on tenofovir or any other therapy and they lose the surface antigen, you could consider taking them off therapy. That is the attainment of functional cure. How often does it happen? Very rarely. Statistically, about less than 1% of the time. But it's good information to have at hand. So this is basically a comparison of the various therapies and how well they work. We can see that the tenofovir and the entecavir have a greater viral suppression, surface antigen loss, and ALT normalization than pegylated interferon. I will not speak too much about hepatitis B infection in pregnancy because that has been dealt with very well by my senior colleague. But I will talk about a few other special populations briefly. So as I've said, for those who have cirrhosis, they should be initiated on therapy immediately, irrespective of the attendant viral load and ALT. Same for those with hepatitis B HIV co-infection. Same for those with hepatitis B, hepatitis C co-infection, and same for those with hepatitis B, hepatitis D co-infection. In the case of hepatitis D, it does not respond very well to the nucleotide analogs, and therefore pegylated interferon is used if there's hepatitis D infection. Fortunately, relapse rates are high. So I'll talk again about the discontinuation indications for the nucleotide analogs. The various guidelines have come up with various indications for therapy. The one that runs through is when there is loss of the surface antigen or when the patient has attained functional cure. Another indication from EASL, the European Association for Study of Liver Disease, is that once a hepatitis B e antigen positive patient has been initiated on therapy, now seroconverted from e antigen positive to e antigen negative, you could have a continuous 12-month consolidation period and then take them off therapy and continue monitoring. The EASL guideline has also said that for patients, select patients who do not have cirrhosis, who have been able to achieve viral suppression for greater than 3 years continuously, you could actually take them off therapy and monitor. Now, personally, I have had 2 patients who have been virally suppressed for 4 years. After continuous monitoring, both had their viral loads steadily rise subsequently and had to be put back on therapy. Now, the American Association for Study of Liver Disease has similar indications for discontinuing therapy. That is for those who are e antigen positive who seroconvert on therapy. Keep in mind that for patients who have cirrhosis, there's no stopping, whether e antigen, whether EASL or ASL. So let's move on and talk about pegylated interferon therapy. This therapy was previously the first-line therapy before the advent and the popularization of nucleotide analogs. Now, it is given via injection. It's given for a finite period of about 48 weeks, and still, even today, can be used for mild to moderate chronic infection. However, it requires regular monitoring, is still plagued by quite a number of side effects, including injection site reactions. The virological response is not as effectively attained as the nucleotide analogs, and there's the risk of the virological response relapse. And for this reason, because the pegylated interferon was not always effective, sometimes or quite a number of times, it would not even make sense to go all the way to the 48 weeks. So some stopping rules were devised such that when you see certain values and certain parameters, you can basically tell that you're not going to get a good response and you might as well stop the therapy and not go all the way to the 48 weeks. So what do we need to know in order to utilize the stopping rules? We need to know the genotype of the hepatitis B. We also need to know the surface antigen level. And these can tell us whether it's useful or not to progress and to finish the 48 weeks altogether. So for patients who are e antigen positive, once the genotype is A, by week 12, if there's no decline in the surface antigen from baseline, stop. You're not going to get a good response by 48 weeks. Now, if for some reason you progress to week 24 and the surface antigen is still greater than 20,000, there's no need to continue. For genotypes B and C, if at week 12, the surface antigen level is still greater than 20,000, stop. If for some reason you progress to week 24, and the surface antigen is still greater than 20,000, again, no need to continue. You should stop. Now, for genotype D, if at week 12, there's no decline from the baseline at all, there's no need to continue therapy. If you continue to week 24 and the surface antigen remains greater than 20,000, again, no need to continue. This is for a patient who is e antigen positive. If you have a patient who is E antigen negative, okay, this is for genotype D. If there's any decline in the surface antigen, and there's the viral load levels are also being monitored, any decline at all from baseline, you can continue. However, if there's no decline, you determine and see, has there been a greater than 2 log decline at week 12? If there is, you could continue. But if it's less than that, there's no need to continue. These stopping rules can be cumbersome. I don't think you need to commit it to memory. It's just good to know, especially if you're someone who is going to put your patient on pegylated interferon for one reason or the other. Now, pegylated interferon, as I mentioned, is only used in select group of patients. If it's going to be used, ideally, it should be in patients who do not have decompensated cirrhosis. Now, in conclusion, we've spoken about hepatitis B, the indications for therapy, the various agents for therapy, and the stopping rules for interferon, if you so choose to use it. It is important that as healthcare providers, we should have a working knowledge about how to evaluate and manage patients with hepatitis B. Week in, week out, we see the results of not having enough information about how to properly counsel, educate, monitor, and manage our patients with hepatitis B. Now, we should have a clear idea of which patients need to be initiated on therapy and which patients we can confidently monitor. For those who have hepatitis B chronic infection, still, there is the misconception that the therapy can be taken for a finite period, stopped after 3-6 months. When the viral load is undetectable, they can stop. This is not true. We should disabuse our patients and other healthcare providers about this incorrect information. The symptoms of acute hepatitis B and chronic are subtle. Therefore, we should be more proactive in screening our patients. You have a high prevalence in sub-Saharan Africa and in Ghana. And unfortunately, some of the strongest people in the working class or the working group of this country are succumbing to the complications of chronic hepatitis B. So thank you all very much for your attention. I will pause here for any questions or comments. Thank you once again.
Thank you very much, Dr. Alpha, for that brilliant presentation. We'll soon go through our Q&A, but before that, we have a very brief presentation by Mega Life Sciences.
Good evening, everyone. My name is Renee Afo from Mega Life Sciences. I'm a product in life sciences. At Mega, we say we care about your health, we care about your wellness. And this drives our passion to develop quality medicines in order to improve upon the quality of life of our patients. Mega Life Sciences has good manufacturing credentials in Thailand and in Australia. And in Ghana, all our medicines are registered with the Food and Drugs Authority. For today's presentation, we'll be looking at the importance of liver-lymph as an adjunct in the management of viral hepatitis. And then also we'll look at a few key Mega brand reminders on Nomagat, Limza, and Avarin. So moving on straight to liver-lymph. We are saying that the liver is the largest internal organ of the human body, and it constitutes about 2% of an adult's body weight. The liver is responsible for several functions. It helps in the emulsification of fats during digestion through the production of bile. It helps in detoxification. It helps in the storage of glycogen, and it also helps in the synthesis of globulins, cholesterol, phospholipids, albumins, amongst others. Some causes of liver disorders include congenital defects, infections and inflammations, poisoning and drugs, autoimmune disorders, and metabolic disorders. Some types of liver disorders include viral hepatitis, which is our topic for today, steatotic liver disease, or what we call fatty liver disease, autoimmune conditions inclusive of primary biliary cholangitis and primary sclerosing cholangitis. And then also we have our drug-induced liver damage. Viral hepatitis, which is our topic for today, is an inflammation of the hepatocytes or liver cells as a result of installation of viruses within these cells. Viral hepatitis comes in 5 types. We have the hepatitis A, B, C, D, and E. Hepatitis A and E being spread through the fecal-oral contamination, whereas hepatitis B, C, and D being spread through infected blood and other body fluid. When hepatitis B, C, and D is untreated for a long period of time, it develops into chronic infections and inflammations, which can cause scarring of the liver, or what we call cirrhosis. So what basically happens? When the viruses get installed in the liver, the immune system is activated, and this causes inflammation of the liver cells and an ultimate damage of the liver cell membrane. And finally, we have fibrosis and cirrhosis. So the chronic inflammation which occurs as a result of the untreated hepatitis B and C viruses, as well as oxidative stress, have the ability to reduce the antioxidant effects within the liver cell membrane. And this also increases the membrane phospholipid degradation through lipid peroxidation, resulting in perforation or holes within the liver cell membrane and causing the biomolecules to leak out of the liver cells. And this ultimately results in liver cell death and liver damage. So this is a pictorial representation of how porous the liver cell membrane looks like and how the biomolecules leak out of the liver cells. This is also another pictorial representation of how the phospholipid cell membrane looks like, and the basic building block, which is the first other building blocks like the phosphatidylinositol and the phosphatidylserine. But for today's conversation, we'll be delving more on the phosphatidylcholine. And like we are saying, it is the major building block of the phospholipid cell membrane, and it constitutes about 80 to 90% of the liver cell membrane. It acts as a barrier first, and it also acts through metabolic transport and enzymatic activities. Whenever there's chronic inflammation or increase in free radicals or oxidative stress, this phosphatidylcholine is degraded over time, and this results in fibrosis and cirrhosis and ultimately liver cell death or damage. And that is why it is important to always supplement the liver with phosphatidylcholine to help replace the degraded phospholipids. And this is why Mega Life Sciences decided to introduce Livolin Forte, which is our 3-in-1 hepatoprotector containing essential phospholipids, vitamin B complexes to help in faster recovery of the cells, and vitamin E to help offer potent antioxidant effect. Livolin Forte dose is 1 to 2 capsules 3 times daily with meals. Some side effects of Livolin Forte include abdominal pain, nausea, diarrhea, loss of appetite, dizziness, amongst others. And for contraindications, persons who are hypersensitive to phosphatidylcholine or any other ingredients in Livolin Forte should not use Livolin Forte. Also, pregnant women and breastfeeding mothers also should not use Livolin Forte. Looking at a few reminders, we first want to look at Nomagat, which is our freeze-dried yeast of Saccharomyces boulardii, which comes in the 250 milligram capsule. The intestinal microbiota is made up of about 1 trillion microbiomes.
Can you skip this and just, because we are running out of time.
Okay, please. Okay, please.
Thank you.
All right, so I'll just touch on the final. So Nomagat is our freeze-dried yeast of Saccharomyces boulardii, which is our probiotic on the market. The dose for normal gut for children 2 months to 2 years is 1 capsule daily. And for 2 years to 12 years is 1 capsule 1 to 2 times daily. And for children 12 years and above, as well as adults, it is 1 capsule twice daily. Then moving on to the second reminder, we have Limza, which is our brand of enteric-coated omeprazole 20 milligram and domperidone sustained release 30 milligram for your GERD, NES, gas, and dyspepsia cases. Then we also have Alvarin, which is our Alvarin citrate and simethicone combination to help in symptomatic treatment of your irritable bowel syndrome, peptic ulcers, dysmenorrhea, and diverticular diseases. Thank you all very much.
Thank you so much, Mega Life Sciences, and thank you for your contribution towards our webinar. So we'll now look at our Q&A, which will be answered by our presenters. So we have a question here congratulating you all on the presentation. Now the question here is, thank you for subsidizing TDF. Is there any plan to subsidize TAF as well, since it seems to be kinder to the kidneys? Dr. Adiboka.
Emily.
Yes.
Yeah, thank you very much for the for the question. So for the tenofovir, with our partners, the one we have been able to secure is the TDF. But if you happen to also get a company that is able to scale the TAF, why not? So we are still working to see whichever that is available. Definitely we'll have people who would need the TAF because of renal impairment. So we are still working on all of them. But for now, what is available is the TDF.
Okay, thank you. So the second question, I believe, has been answered by Dr. Arthur's presentation as to when to put patients on medications. Dr. Adiboka, this is also to you. They want to know if you have any timelines with regards to the introduction of the birth dose.
For now, we've not scheduled a guideline. We are still working up. We are coming out with the awareness creation materials. We are yet to meet the stakeholders, and we'll look at which day we are going to roll out the vaccine. So very soon. So I will updating the public concerning that one.
Okay, thank you. Someone wants to know if there's a schedule for the vaccination for babies born to hepatitis B positive mothers. Dr. Mwakudia.
Okay, so once the mother is positive at birth, the baby have to receive both the vaccine and the immunoglobulin at different sites. Okay, and then the baby will continue with the routine childhood immunization for the rest of the hepatitis B vaccination. So currently, the birth dose one that they don't get it routinely, but after the birth, once you give the birth dose, then you continue with the childhood vaccination one.
Thank you. Someone is asking that considering that vertical transmission is one of the most common cause of chronic hepatitis B, they are wondering if the Ghana Health Service can help with the reduction or possibly absorbing the entire cost of the hepatitis B immunoglobulin for the hepatitis B exposed babies, especially those in the rural areas. Dr. Adiboka, can you give us some insight on this?
Yeah, so that will be quite difficult. When you're looking at universal care, you look at what would cover most of the people. So another way is to introduce a birth dose. So the option is either you give immunoglobulin or you give the birth dose within 24 hours. So for trying to come out with immunoglobulin for people, it will be quite difficult. So the best thing is the vaccine. But for now, I don't know whether government will be ready to subsidize that. But what government is doing is to get the birth dose available for every child or newborn.
All right. Thank you very much, Dr. Adiboka. The next question, I think, if you can handle it as well. Someone is asking if hepatitis B can be gotten through sweat.
So, no. So as I was talking about the myths, handshaking, sweat, eating with other people, you do not get Hep B from that.
All right. Dr. Amakudia, someone wants to know the immunization protocol for babies with birth weight of less than 2 kg.
So it follows the same way as those whose weight is more than 2 kg or 2 kg or more. Just that, I mean, they need to receive four doses, which is happening currently in Ghana now. So when they are less than that, we consider the first one, like we don't count the first one, because at that stage their immune system is not well built up. Okay, so you give it to them anyway at birth, and then they receive the other 3 doses as per the national immunization protocol.
Okay, thank you. I believe questions related to when to start and end treatment have been addressed by Dr. Arthur's presentation. Someone wants to know how to reassure households of patients who have been infected with chronic hepatitis B, how to reassure them to continue living as normal with the affected person. Dr. Dia.
Sometimes it's difficult because of the I always say that is the false information that is in the public domain. And this false information sometimes comes from we, the health workers. That's why we need more education. Because sometimes you go to a health facility and education is being given and they are telling those who are there that you can get the hepatitis through sweat, through saliva and all those things. So once they get this information from health workers, they take it as a gospel truth. Okay, so it's for us to educate the public, to educate the family. To know that the only way that you can pass the infection from one person to another is through blood and then the sexual fluid. Okay, I think when they get the education, they will be more reassured. And most of the people that come to clinic, when you tell them this, they are more reassured and they are able to live together. Especially when they come and they are partners. I always tell them, you have given birth to 3 with your husband. You don't have the hepatitis B. Okay, so why should you be afraid that you will get, or anyone in the family will get hepatitis B through contact with the person who is infected? So it's more of education and just reassuring them. Thank you.
Thank you very much. Someone wants to know what is characteristically significant in the male gender that predisposes them to develop cirrhosis.
So if I may come in, study shows that the female hormones tends to protect them, from the progression of liver disease, especially the estrogen and progesterone. Okay, so female in their productive age group, they get that kind of protection. And then also, so when they are in the menopausal age, you realize the risk tends to be the same for both men and women. The other thing that you also consider is that men also tends to involve or indulge in other risk factors that put them at risk of developing or having a progression of liver disease, like excess intake of alcohol, smoking, and other things that put them also at risk. So these are the two main major reasons why maybe men tends to progress more than women. Thank you.
Okay. Someone wants to know if an infected chef can infect the household through cooking.
I think this is one thing too that the National Health, Ghana Health Service, and then the control program, need to work with the district. Is it the public health people? Okay, to let them know that why should we screen chef? Why should we screen people who cook, who sell food outside of hepatitis B? Do we think that they will pass the infection to those who are coming to buy their food or what? Okay, as we have all learned, it's through blood and blood product. Okay, so I think that one should be taken out of before they get the food certificate, they do that. And it's making a lot of young people lose their job, all because the public health unit of a district have gone to a restaurant, have gone to a hotel, and they screen them, and it come out to be positive. And they ask them that they have to go and get treatment and get themselves cured. That we also know that as for the surface antigen, it will remain, and it's only few people that are able to lose their surface antigen. So I think this one, Ghana Health Service should take over. They should take away hepatitis B screening out of the food sellers or the chef. If they want to check for anything, let them check for A and E, because it's that one that spread through food. But that one too causes acute infection and is not dangerous as B and C. So I think this is the answer that I will give. Thank you.
Thank you very much, Dr. Dia. Dr. Arthur, please, someone wants to know that if a patient loses the surface antigen after treatment, can that person be vaccinated?
So, first of all, the surface antigen being lost after treatment rarely occurs. Statistically speaking, probably less than 1% of the time. So for such patients, you still have to monitor because there is a tiny risk of reactivation, especially if they are exposed to any immunosuppressant for any reason. So the risk of liver disease is markedly reduced, but it is still there. And well, first of all, I think that even the attainment of surface antigen in my 16 years of being a doctor, I'm yet to see it. I don't know if Dr. Dia, you have actually seen someone lose the surface antigen after being on therapy for some time.
Okay, thank you. Dr. Adiboka, someone wants to know whether the control program has any protocols or guidelines available for the treatment of chronic hepatitis B.
Yeah, we do have guidelines. The data we are yet to update them. The last time the guidelines were updated was 2017. So we're updating the new guidelines, and it will be made available to every hospital. Thank you.
All right. Thank you very much. There's a question here on hepatitis C, which will defer because we have another webinar next weekend that would delve into the management of hepatitis C. So let's look forward to that one. All right. So someone says,
Emily,
is there?
my hand has been up. I just want to ask a question.
Yeah. All right, boss.
Yes. So, Dr. Atta, you have given us a very brilliant lecture, which might be simple for you, but for many of us, it is still complex. Now, I've also heard Dr. Dia say that for him, he doesn't stick to the guidelines. If you are positive and your viral load is more than 2,000, he treats you irrespective of your liver tests and all the other things. The question I want to pose is, if Dr. Dia, who is the specialist, is deviating from guidelines, why won't you allow all of us to treat anybody after all? Is there any disadvantage in not treating everybody? Thank you. Because I know the Chinese have actually revised their guidelines so much so that they're almost treating everybody.
Yeah, Dr. Techi, thank you. That's a very brilliant point. As time has gone on, we have seen that there's been expansion in the patients who are qualifying for therapy. And I would always liken this to what was happening with HIV a few years ago, where there was a strict criteria with regards to the viral load and CD4 count before therapy was initiated. Once HIV has become a program drug condition, now virtually everyone who tests positive is initiated. We may very well get to the same point with chronic hepatitis B in the near future, where if there's the availability of the medication, the cost is reduced, or if tenofovir becomes a program drug such that it is applied by the government, we could very well put everyone on therapy. Now, the guidelines that we have are simply guidelines. They guide our therapy, they guide our management. If, as a clinician, in your personal opinion, you feel that the guidelines are rigorous, they don't meet the needs of our patients, or we cannot follow them for one reason or the other, there's absolutely nothing wrong in initiating therapy for every patient who you see. Better safe than sorry. As we have seen, the large burden of hepatocellular carcinoma is seen in the young African sub-Saharan in sub-Saharan Africa. And in Ghana, the 30-year-old, the 20-year-old, the 40-year-old is much more likely to develop hepatocellular carcinoma than his counterpart in the United States or USA. So Dr. Dia is doing what a lot of us would probably be doing in the very near future or already doing in putting a lot of our patients on therapy who do not necessarily meet the criteria. Very soon, we may initiate every single person that we see. I think that's a trend that will be following in the very near future.
So boss, if I may add something to it, I think it's the way to go. Because you see, if you have surface antigen present and even the virus is undetectable, you are not free from developing cancer of the liver. The risk is still there, about 1 point something, close to 2%. Okay, so for me, I think that's the way to go. Why don't you treat anybody? Why do you have to wait till the virus go to this number, go to this before we treat? But I think most of us in the like developing country, I mean, all what we think about is that will the patient be able to afford the medication? Can they be on the treatment? I mean, for the long-term treatment without breaking it and maybe leading to resistance. I mean, these are the things that we have also be talking and discussing about. But for me, in my clinic, any patient that I see, I discuss this with the patient. Once the patient is willing to be on the long-term treatment, I start. If the person doesn't meet the current criteria and the person wants to wait, yes, we wait and we monitor the patient. But I think it's the way to go. I mean, if you are treating anybody who tests positive to HIV, why don't we treat all those who also have hepatitis B? Since you know that hepatitis B is a carcinogen, the virus itself is a carcinogen. Why do you want to walk around with a virus that can cause cancer in you? Okay, so I think we need to look at this and get affordable treatment or bring these patients on NHIS so that they can get access to the medication. And I think for me, Ghana, looking at this burden in our country, we need to find a solution to this. And I'm happy most of the Ghana Health Service people are here. I mean, we get data almost every year, and we know diseases that are killing us. And we know that hepatitis B is a problem, so we need to tackle it. I mean, so that it stop killing the youth. It's disheartening being at the clinic and seeing these young ones coming in with cancer all the time. And when they come, you don't have a good news for them. Okay, so I think we need to look at viral hepatitis very well, especially the hepatitis B, so that we can confront it from all corners to defeat this virus that are causing harm to all of us. Thank you.
Thank you very much, Dia and Dr. Arthur. Dr. Micah, please, your hand is up.
Yes, please. Thank you very much. It's been an insightful presentation and I really enjoyed it. I'm just wading into the topic about treating and treating all. I always say that the infectivity of individuals will go up once the viral load is high. So if we are able to treat a lot of people and the viral load is low, then transmissibility will be reduced and we'll be able to get a hurdle over the burden of hepatitis B in the country. And I always tell my patients that if we are giving you treatment for hepatitis B, you see it as your tap is fault, and you put, instead of calling a plumber, you put a block on it for it to stop flowing. The moment you remove that block, water will gush out. So the tenofovir that we are giving you is preventing the virus from multiplying. Once that effect is off, then the virus will start multiplying again. So once you go on treatment, make up your mind that you are going on it lifelong until the surface antigen is negative. So if we educate our patients that way, I'm very sure we'll get a lot of them taking their treatment rather than stopping. And if you see a patient whose family history, there's a history of cancer, liver cancer in the family, you have no business deciding that you are monitoring the viral load until it gets to 2,000. That patient has a higher risk of developing liver cancer. So the earlier you put the patient on treatment, the better, so as to reduce the risk of developing liver cancer. Thank you very much.
Thank you so much, Dr. Micah. Someone wants to know that after exposure to hepatitis B infection, if vaccination is initiated immediately, can the chronic hepatitis B infection be prevented?
Not vaccination, maybe the immunoglobulin. But I don't have any data on this, and I haven't seen any studies on this one too, that when you get exposure. But I think once you get the exposure and then you get the antibodies, because the antibodies will neutralize the antigen and it will not make the virus establish, okay, the infection establish. That one, because one thing that we do for patients who have not responded to hepatitis vaccine and they get exposed, you give them the immunoglobulin. So I think the immunoglobulin can help if the person have not been vaccinated before. Once you give the immunoglobulin, then you start the vaccine. That one can help prevent the person from getting the infection.
Thank you very much, Dr. Dia. Dr. Sebastian Amwa, please, your hand is up. Dr. Kenamwa. All right. Okay. We'll continue.
Hello. Yes. Can you hear me?
Yes, we can.
Yes. Thank you for the insightful presentation. I just wanted to talk a little about the argument that was made just a few minutes ago. I think that issue of people treating by their own experience and their own discretion will rather lead us to a chaotic situation if we decide to pursue that course. I think this calls for a national guideline, which will guide all of us. I mean, I think that the one that was presented to us more or less it was a general guideline. I mean, an international guideline that is supposed to actually be adopted by jurisdictions. So I think that we have to come up with a national guideline so that then our practices can be guided and it to be uniform rather than each person managing such cases at their own discretion. So that's what I just wanted to add. Thank you.
Okay, thank you so much. Dr. Nate, can you please help us with questions from the YouTube channel that haven't been addressed yet?
Thank you, Dr. Norte. Yes, so there's a question from the YouTube which says, I think this goes to Dr. Adiboka. It says that in the antenatal clinic register and the DIMS 2, the means of capturing data for hepatitis B is not there. What is the program doing for this data to be captured? Thank you.
Yeah, so I think this one has come to our notice for some time now. So we plan in engaging the DIMS for us to have an orientation on that, and then we plan also having a meeting with the midwives on how to make on how to take out some of those data. So I think we'll relook at it as we are coming to introduce a triple therapy, triple elimination very soon. So those ones will be sorted out.
Thank you. There's another question here that says that since they are talking a lot about mother-to-child transmission, what about a father? Can a child get hepatitis B from their father? I think Dr. Adiboka, you can take that one too.
No, so the answer is no. Is the transmission or the contact will still be like the general form of transmission through blood to blood or body fluid.
So
There is no
horizontal
genetic.
transmission, so
Yeah, it's
horizontal
just
transmission from the father, right? Household
further, yes.
exposure.
Yeah.
Okay, thank you, sir. Okay, I think this one goes to Dr. Arthur. It says, if an HIV client is already on tenofovir and tests positive for hepatitis B, what must be done?
So we have already mentioned that tenofovir is the first-line nucleotide analog for the management. So for a patient who has hepatitis B and HIV, they are inadvertently already on treatment. The only thing that we would do additionally is we are still going to screen them for progression to cirrhosis and HCC, because we know that once a patient is on tenofovir therapy, it markedly reduces their risk of progression to cirrhosis or HCC, but does not eliminate it altogether. Retroviral infection is a chronic inflammatory condition. And for that reason, the only thing we are going to add is our screening for cirrhosis and HCC. But tenofovir is treating both conditions concurrently.
Thank you very much. There are a few questions about hepatitis C, but I think as Dr. Norte said, in next week's webinar, we will touch on hepatitis C. So please, we are done, Dr. Norte. Thank you.
Okay, thank you. Dr. Dia, there's a question here about herbal supplements such as tea, capsules, and syrups being marketed as a cure for hepatitis B. How true is this?
You are asking me, Heber.
A lot of people seem to have a lot of questions.
As for them, you see, I ask those who ask me that, have they seen any FDA-approved drug, herbal medicine in this country that have been licensed to be used to treat or to cure hepatitis B? And there is none. Okay, so these are charlatans in our system that we need to fish them out. And I've seen so many people that have been depending on these charlatans. They have drained all their bank accounts, and at the end of the day, the virus continues to be there. So there is no herb that have been approved that we know that can treat or that can cure hepatitis B.
We'll take our final question. Someone is asking, we'll take our last question from the Q&A and then one live question. So the one from the Q&A is asking about the need for a booster if you haven't taken the vaccine, if you had taken the vaccine a while ago, whether you need a booster.
So now hepatitis B is like yellow fever. Those times you used to take a booster every 10 years for yellow fever, but now it's no more. The same way applies to hepatitis B. There is no need for a booster if you responded to the initial 3 doses of vaccination. But what we should know is that all those who get the 3 doses, about 10-15% do not respond. Okay, especially the elderly people, those who are 40 years and above, those who are like hemodialysis, those who are immunocompromised, diabetes, retroviral infection, those who are cancer on chemotherapy. These people may fail the first 3. So if you are a health worker and those who are at risk, what we recommend is that when you get your 3 vaccines, 1 month or 2 months after the last dose, you check for your titer. If you check the titer and you have responded, that is fine. If you check it again and you have come below 10, then you can get a booster. Otherwise, booster is not recommended for the general population. But if you are at risk group, if your titer drop below 10, then you can get a booster to boost your titers.
Thank you very much, Dr. Bia. We'll take our last question from Dr. Akatiba, whose hand is up.
Hi, thank you so much, Emily. And thanks to our legendary presenters and chairman for the educative session. I have a couple of very practical questions and to address to each of the presenters. So the first one is to the program manager, Dr. Gerald. I think we've engaged a couple of times on this, but since we've seen the Ghana Health Service, the boss himself, Director General and all of that are involved, it's good to bring up the advocacy again as well, especially in rural northern Ghana where the prevalence is a real big issue. So to the part that is very dear to my heart, the babies who are still acquiring hepatitis B in this day and age, which to me I think is grave injustice. They did not do any wrong. It's just because they were born in Ghana. You take the child health records and look at the EPI and the vaccination schedule, the BEV dose is right there. So I find it so inhumane that in the northern part of Ghana, where the prevalence is that huge, we can't even administer as a country or approve as a country the BEV dose if the people cannot even afford the immunoglobulin. How much is the BEV dose that stakeholders in health, whether at the regional levels or any of that, can't come together to get this out? Because I think that is the cornerstone of us preventing the future generation, as one of the summary points we pick up. So my appeal is that let's really look at this. We can't wait for it any longer. We can't wait until it becomes a nationwide thing. How can we practically, as a program manager or as gas lead or as directors in the health service, be able to tackle this very basic need, which I think is inexpensive, that could be. I have a personal example where my wife gave birth and then the nurses did not even know that a BEV dose will be given because they asked her if she's hepatitis B positive and she wasn't. And this is in the northern parts of Ghana where the prevalence is even bigger. So I don't know what is in stock and if it can be done urgently rather than wait till donors come in or any of that. I think we can. Looking at the fact that we always say Aprotec, we would be able to find ways of going around it. If it is halving the adult dose or any of that, let's guide our practitioners, especially where the prevalence is high. The second one is about the treatment. I think maybe I may have been a prophet some 4 years ago when Dr. Atta joined us for a webinar. And I did ask a similar thing because back then it was a viral load of over 200,000. And I asked whether hepatitis B will not go the way of HIV in the future. And it looks like we're looking at something like that. And I think one of the things that one questionnaire asked was a way to standardize things. Yes, guidelines are supposed to guide us. And so if we can, as GASLID or as National Viral Hepatitis Program, can lead those discussions towards a research-based kind of approach to it in our local domain, looking at what Dr. Techi did mention, i.e. the expert guidelines that Dr. Mwako is using vis-a-vis what is in the guidelines for everyone. And I just wanted to draw again the key stakeholders in terms of funding, in terms of getting things forward with regards to that. My last concern has been about employment of those who have hepatitis B. I think we've been a bit political about it, and I'm sure the program manager cannot because obviously it's at a government level. I was wondering whether GASLID could lead this kind of advocacy, wherein a minister then says those who are hepatitis B positive were disqualified. And I think that does not order well for the stigma that we've been trying to go against. And we never saw any press statement. We never saw any engagement with regards to that. And so the politician always has his way when it comes to these things because our hands, like we always say, are tied. So I was wondering, in addition to all of this that is happening on a national viral hepatitis platform, how best we can approach a couple of it to get the practical emphasis like I've laid. One, getting the children out from infectivity, which has been demonstrated by the Thailand example and a couple of the countries that are out of it. And then as well, the BEV dose and employment issues. Thank you so much, and over.
Dr. Adiboka.
Tommy, thank you very much for the extensive and detailed questions. Yeah, so first of all, I would like to appreciate the work you've been doing across Northern Ghana too. I know you were contributing to the awareness creating in Upper West region. So we appreciate your work. In terms of the BEV dose you spoke about, I think that is the cry that we are also looking at. And to be frank with you, the BEV dose implementation was just being signed, I think about 2 weeks ago. And I think after we had the information, the government have signed, we have been putting pressure on some of the activity we need to do. I think I had a meeting with Director General, and we are also pushing towards even the 28th, we are going to have World Hepatitis Day celebration. We'll be mentioning it and also talking about it. We know that if all these are being brought out and people understand that BEV dose is important, sometimes you may not need to also wait for government to come out with everything. As individuals, if education awareness is being created and everyone knows that if my child is being born today, the best way to prevent her B is to give a BEV dose. We can make it available for everyone, not necessarily waiting for government. For government is coming out with that and everybody will cover it. If it comes to a point that they have to decentralize or look at district or regions that are highly prevalent and they can probably implement across the whole region, I think we'll recommend all those ones be done across the northern part of Ghana. And I think there are some other possibilities of tenofovir for pregnant women that we are working on. So for us as a program and as a Ghana Health Service, we are linking up to everybody in terms of the vaccine and the treatment. And for the treatment, as you said, I always say that the only reason why we are not putting all our people on treatment is the fact that the drug is not available, it is not accessible. Just like hypertensive. If we have hypertension, the only thing you are doing is to prevent stroke, heart attack, and complications. And it's the same thing like having viral hepatitis B infection. Why will you wait until the person develops liver cancer before you treat, or liver cirrhosis? So, and the hypertensive drugs are available. It's on health insurance. You can easily buy. It's everywhere. So we are working to make sure the drug is available everywhere. And then when you nationalize it on our guidelines, then people can afford. And for the guidelines, as I said, I think Gaslit and ourselves, we had a meeting last week, and we discussed about when to update the guidelines. I think we'll do that soon and put in the public so that people can access it, and it will help in the treatment of viral hepatitis in Ghana.
Thank you so much, Dr. Adiboka.
Emily,
Thank you.
if you don't mind, I will just jump in very quickly to just speak about an example and based on what Dr. Katiba mentioned with regard to birth dose and not necessarily waiting for national rollout. So in a small project that was done in Cape Coast where antenatal clinic nurses, midwives, pediatricians, etc., were educated on hepatitis B, PMTCT, on birth dose vaccination. We were able to undertake a quality improvement project that looked to see the acceptance of birth dose after this intervention. What we found was uptake of the birth dose where the pregnant women were offered the vaccine at a cost of 25 cedis. Uptake was around 80%. When the vaccine was free, uptake was 100%. So even where pregnant women have had to pay for the vaccine for their babies, we've seen that uptake is still quite high at 80%. So maybe similar models could be tried whilst we wait for national rollout. That's just to buttress the points that Dr. Katiba was making. Thank you.
Thank you very much. And thank you all so much for your contributions. We'll take our chairman's closing remarks now.
Good evening, everyone, and thank you for staying on this call till this time. We are grateful for your attendance. And I think that the discussions have been quite thorough, and there will be no need to summarize, but just to say a few points. Hopefully, our policymakers on this call have gotten the message that we can't wait any longer for birth dose. Even if it means that the mothers have to pay something, let's roll it out. At least more people will be able to enroll than we are doing currently. And for our practitioners, for mother to child, Dr. Dia has told us that you do not even need to have a viral load. Just knowing that the patient is hepatitis B antigen positive is enough for you to begin to treat that person preemptively to prevent mother to child transmission. Yes, if the patient is E antigen negative, then you have the difficult task of trying to determine the viral load, then whether they will qualify for therapy or not. And as we have all learned in the last few discussions, the experts are doing something different from what they are telling all of us to do. So we are pleading with these experts, please come together, update your guidelines so that all of us can learn from your expertise and not just be practicing what is simple and leaving the rest of us to, hustle with very complex viral load antigen, and the evidence out there is that in some places where hepatitis B is endemic, they have taken this route and the results are beautiful. So I thank you all once again, and I'm sure that there'll be some vote of thanks to thank you even some more. Thank you.
Thank you very much, Dr. Tachi. So like you said, by way of vote of thanks, we want to first of all thank the Almighty God for bringing this webinar to a successful end. We thank our chairman for steering affairs. We thank our presenters for such insightful and excellent presentations. We thank our audience for sticking with us. We thank you for all the questions. We thank you for your participation. We thank you, members of the Ghana Health Service, for your presence. We also want to thank our sponsors, Mega Life Sciences, for always supporting our programs. We thank you all so much. Akwe. So now we'll take a closing prayer by Dr. Fatima Mohammed.
In the name of Allah, the most gracious, the most merciful, I pray for the presenters that Allah richly bless them for imparting the knowledge to all of us. I also pray that whatever we learn today, we would use it to help in breaking down the barriers to hepatitis elimination in Ghana. And I pray for GASLID as an association and all of us, the attendees. Thank you.
Thank you very much, Dr. Fatima Mohammed. We are going to have some final words by our Director General. Dr. Kaba Akorie, please, your audience. Dr. Nate, please, is he still on the call?
I think he just dropped off. Maybe network issues. I think he just dropped off. So it's fine. Maybe next week's webinar. So you can just go ahead.
Okay. Thank you all so much for your participation. Kindly look forward to round 2 next weekend, which will be looking at hepatitis C. So we will meet you all again, same time next week. Thank you. Have a good evening.